Thank you very much for the invitation. My name is Dr. Miguel Ayala León. Today we will discuss a clinical case at Aorta Hub that we reviewed in the consultation, a bicuspid aortic valve with rare congenital abnormalities associated. We are discussing a 63-year-old patient who visited the consultation because an apparent aneurysm of the descending thoracic aorta was discovered during a clinical evaluation by internal medicine. The patient reports that he consulted with the internist due to a feeling of tightness and shortness of breath with physical exertion. In the physical examination, we detected a systolic murmur accompanied by a protosystolic click. During the evaluation of the complementary tests, we found during the echocardiographic evaluation that the patient does not actually show dilation of the root of the aorta. He possesses a bivalve aorta with no raphe present, a genuine bicuspid aorta, as it is referred to. No stenosis or insufficiency was observed. The left ventricle functions well. The patient has no diastolic dysfunction. The chance of pulmonary hypertension is low. No significant abnormalities were detected aside from the valvulopathy, which does not seem to have any significant damage implications. Here are the interesting questions. Why does this patient at this age have a valve without significant dysfunction? This echocardiogram fails to clarify the reasons behind angina and functional deterioration. This prompts us to explore further to understand better. The reason may be a stress test, a dobutamine study, or a non-invasive study to see how the coronary arteries are doing. That's why we decided to address this as well. The topic of aortic coarctation, since during the Doppler study, we did not really find an acceleration velocity in the aorta. We did see a very characteristic Doppler flow change with turbulence and aliasing in the descending aorta, but we couldn't detect high velocity flow. So we conducted a complementary study with a coronary angiography, which we observed in this coronary angiography, and you can observe how there is a post-stenotic dilation of that apparent image of an aortic coarctation. But what stands out is that it is not really observed that it is a coarctation. When unfolded, it is simply a bend that the aorta makes, and it is a pseudocoarctation, with this image showing dilation of the thoracic aorta following this pseudocoarctation. Since the change in flow has generated itself over the years to altering the structure and dilating the aorta. What caught our attention in this case is that the patient presents a single coronary artery that arises from the left sinus. This is the unique coronary artery that supplies all the anatomy and blood flow to the heart overall. Thus, we also managed to clearly demonstrate and characterize the image, as you can see, of a true bicuspid aorta without any raphe or anteroposterior opening, and we also observed that there were no angiographic lesions in the coronary artery, being the only artery present. So the questions that arise next are: is there a connection between the type of injury the patient has and this unique coronary anatomy, along with the underlying pathology such as the bicuspid aorta? In this fascinating review, as you can observe, there are coronary anomalies that have been studied and are associated with the bivalve aorta. When we evaluate a patient with a bivalve aorta, we should also look at the coronary anatomy, not only the structure of the aorta or the valve itself as an aortopathy, but also this disease is not just valvular or aortopathic, but there are also alterations in congenital coronary arteries, as seen in our case. Notice how it was also referenced here in this article that there are unique coronary arteries. They documented that these occurrences are not as frequent as the connection of other coronary sinuses, or that only the left coronary sinus or the right coronary sinus may have other types of abnormalities like high ostia or fistulas. But also consider that the origin of a single coronary trunk is present, meaning its presence is indeed observed. So, all patients with a valve issue who have congenital aortic valvulopathy, such as a bicuspid aorta, 1 to 2% of the population presents this condition, and within these patients, almost up to a maximum of 1% may have the presence of single coronary arteries, as is the case with our patient. Now, the question is, at this time, in this age range, why does the patient who comes in with dyspnea, who comes in with functional decline and angina episodes, lack any valve issues, insufficiency, or stenosis? Notice how in these two slides, patients who truly do not have raphe have a true bivalve aorta due to the alterations, how flow is naturally maintained, and how hemodynamic balance is achieved. There is minimal damage at the valvular level compared to other bivalve aortas. And for instance, in this case of no raphe, there is no significant stenosis, and similarly, patients without raphe do not exhibit significant insufficiency. Thus, primarily, we can say that patients with a true type 0 bivalve aorta tend to experience less damage to their valves. Less valvular deterioration occurs, making them patients in which there are no very clear hemodynamic alterations and there is no valvular damage. What happens? In contrast, patients with a raphe experience more flow changes, valve damage, increased stiffness, and stenosis. Early calcification occurs due to the risk of valve damage. In response to our patient's question, the reason for no damage is clear. It was a bicuspid without raphe. Coarctation of the aorta in the review we conducted is indeed commonly associated in most cases. In this case, almost up to 34.2% of patients, and it was one of the primary causes associated with bivalve aorta. If you take a look at this table to the right, in this comparison, you can see patients who have, and I opened the discussion by stating that the ascending aorta is larger in patients with bicuspid aorta who have an aorta abnormality such as aortic coarctation. In contrast, patients without aortic coarctation show less dilation. So when we evaluate echocardiographically and find that the patient does not have dilation of the aortic root, it is likely that this patient does not have aortic coarctation. And in those with aortic dilation, we must intentionally look for aortic coarctation, although most patients with bicuspid valve has aorta dilation. We really did not find it. What can I say? We did not find a coarctation based on flow acceleration criteria. It appeared more like a bend and a dilation after this bend, which is termed pseudocoarctation of the aorta, which is not very frequently described in cases. Let's delve a bit deeper to understand what is happening. I mean, are these truly isolated findings, or is there a genetic basis? Let's look at the graph below. We possess two genes indeed. One is the GATA gene, and the other is the negative GATA gene. This resulted in patients, specifically mice with these genetic alterations exhibiting flow acceleration. They exhibited enhanced speed gradients, which you can observe here, with a higher flow rate in the negative GATA-GATA. And upon observing them later through echocardiography and anatomopathological means, these patients have a bicuspid aorta, correct? And even the patients with large vessels and the origin of the coronary arteries are the GATA, right? These patients will also have alterations in the coronary arteries. Therefore, aortopathy and aortic valve disease are genetic by nature. So we need to grasp this concept of the valve. The aorta and coronary arteries are genetic issues we need to keep an eye on and understand as common. Not just valve issues or aortic problems. but perhaps go a bit further and examine the congenital structure that may have coronary anomalies. Conclusions. Those with a bicuspid aorta and coronary artery problems have a higher risk of ischemic events, especially if there's an obstruction, as seen in this patient. As a result, the early intervention strategies in cardiovascular care, including lipids control and other cardiovascular risk factors, will be considerably stricter. We need to keep an eye on how this valve is functioning via echocardiography, while also recognizing the advantage the patient has experienced. Due to their bad luck of having a single coronary artery, but there are no actual valve changes as there is no raphe. Pseudocoarctation is infrequent, symptomatology is not observed, and we need a multidisciplinary approach for all of this and to complete the diagnosis of all abnormalities of the patient. We address the patient's clinical condition through these examinations. Even though pseudocoarctation does not result in flow acceleration and there is no hypertrophy in itself, but the patient during physical activity, in terms of afterload, with increased afterload, and this pseudocoarctation worsens, the plan is to perform an exercise test to see the hemodynamic changes this patient exhibits during exercise and to address this question. Thanks.